Hi everybody, and thank you for joining the 2019 MIPS Eligible Measures Applicability Process webinar. During today's webinar, CMS will provide an overview of the two-step Eligible Measures Applicability, or EMA process, including eligible collection types and frequently asked questions. The webinar will also cover EMA's impact on the quality performance category calculation and score. At the end of the webinar, CMS will answer questions from attendees as time allows. So now I will turn it over to Tim Jackson, the implementation lead at the Centers for Medicaid and Medicare Services, to begin.
Thanks, Lauren. Hi, everyone. Thanks for joining us today. So as Lauren just discussed, we are talking about eligible measure applicability, or EMA, and we're going to go ahead and advance through some of the kind of pro forma slides, and then we will get into the content. And I'm happy to share that we'll also be able to provide a bit of a demo for participants today to see how the operations functions on the CMS side, which I know is a question we often have from folks. So let's go ahead and advance. Here's our disclaimers and our agenda. So we're going to cover the process. We're going to cover the functionality within the category, and then the demo and review questions, and also highlight what is the kind of source information, which is the specialty measure sets, and the clinically related measures, which is the logic that EMA uses for its processing. Finally, we'll review the help and support available and take time for questions and answers. And I do want to highlight up front here on the agenda, questions and answers need to focus on the operational or functional processes here. The measure sets and clinically related measures fall through rulemaking and other sub-regulatory processes. This webinar and the Q&A section at the end of this webinar will be focusing on the more technical elements of how EMA functions within MIPS. So thank you, and let's go ahead and advance. So what is the eligible measure applicability process? There are approximately 250 measures available in the quality performance category, and so there are requirements to submit 6 measures or complete a specialty measure set with your submission. So those are the program and policy and therefore system expectations. I need to also call out the expectation is there is an outcome measure available, then it is also expected, and that is not always the case for some of the sets, but with the 6 measures, that is what we have. So unless you're submitting that full set, you have 6 measures and an outcome measure that should be coming in with a submission for the performance period of 2019. Next slide. All right, we're on slide 6. This shows the process checks. This is what Lauren had briefly noted with the intro. There are some factors that when you are a practice using Medicare Part B claims is your collection type, or you work with third-party intermediaries. And those are the 2 submission elements that allow for EMA to be employed in the quality category. When you have those submission types as your preferred or selected submission, you have then a check for fewer than 6 measures or no outcome or high priority measure, and then your submitted measures again need to be Part B claims or MIPS CQM collection type. And I'll reinforce that MIPS CQM collection type a couple times through this webinar, but the bottom line is QCDR measures either in part or in full remove EMA from the process. So let's please advance to slide 7. If you do not meet the requirements, as just highlighted on slide 6, the EMA process determines whether you could have submitted more measures, including an outcome and high priority measure, and adjusts scoring to reflect the measure, the number of measures available as needed. So this is a question we used to have early on in the program. Eligible measure applicability is not eligible measure inapplicability. So EMA does not check for what you couldn't have submitted. It checks for what you could have submitted based off what you did submit. So I'll say that again. Eligible measure applicability is, I'll say it a little differently for the folks that are familiar with coding logic or programming logic. It's a Boolean check, right? It's an if this, then that, or a combination of 2 or 3 if this measure and this measure, then that measure. It is not, I think only one measure applies to me, therefore I only submit it and CMS has to prove otherwise. That's not how Emma works, and doing so does not meet our program or policy or operational expectations. So let's please advance to slide 8. Our collection types. So this is something that we had set forth in rule making and now are reflecting across the program. A collection type is a set of quality measures with comparable specifications for data and completeness. In 2019, clinicians could select their measures from 6 different collection types: ECQMs, MIPS CQMs, registry QCDR measures, Part B claims measures, web interface measures. All right, now let's advance to slide 9. Lauren, can you hear me to advance to slide 9, please? All right, so eligible measure collection types are applied to 2 of those 6 measures, that submission collection types that we had just identified, which is the Part B claims and the CQMs. EMA does not apply to QCDRs or to ECQMs collected and certified electronic health record technology. If you submit QCDR measures or ECQMs alone or in combination with your claims or MIPS CQMs, you're expected to submit 6 quality measures. So again, that EMA logic is tied to the collection type, and if it the process of submissions includes those that exceed that collection type, then the EMA logic is not going to be applied because the system will not look for that that submission flexibility. We can review the policy understandings of why that is in the Q&A, but it's pretty simple. EMA's there to say we have identified things that would allow for a reduction. By not following that reduction path, you are clearly indicating you do not need the reduction path, and the policies do not allow for that reduction path to be applied anyways. So we can review that a little later. And again, the EMA process does not apply whatsoever at all to the web interface. So let's please advance to slide 10. Great. This is how it works. It's a 2-step process based on the clinical relationships between measures. So the Boolean logic, as I had referenced, is an association between the quality measures. These are relationships documented in the claims measures and the CQMs. Step 1 is a clinical relations test or clinical relation and outcome high priority test. The clinical relations test sees if there are more clinically related measures based on the 1 to 5 quality measures you submitted. And the clinical relations outcome priorities test sees if there are any of the 6 or more quality measures you submitted are clinically related to an outcome or high priority measure when no outcome or high priority measure were submitted. Next slide. The second step is a minimum threshold test, which looks at the denominator of the eligible population. So in Medicare Part B claims, we look at the submission to see if there are at least 20 denominator eligible instances for any clinically related but unreported Medicare Part B claims measures found in step 1. And for MIPS CQMs, which is our third party or qualified registry vendor submission, we review the eligible population for any clinically related measures submitted with no performance data. I also read the note at the bottom of the slide. Reported quality measures do not have to meet the 60% data completeness requirement to be eligible for the EMA process. However, quality measures that don't meet data completeness will only earn 1 achievement point towards the quality performance category score, or 3 points for small practices in 2019. So that's a scoring distinction we have here in the note on the bottom of slide 11. Okay, let's go ahead and advance to slide 12. This is one of our FAQs that we've pulled out here for the denominator eligible instances. If I do not have 20 denominator eligible instances for a clinically rated MIPS CQM, what is the process? When a MIPS clinician has less than 20 eligible instances that is clinically related to another CQM, they are reporting the third-party intermediary still needs to include that MIPS CQM in the submission. And there are technical processes and explanations that are provided for how to do that. In the instance where a clinician or group doesn't have any denominator eligible instances, the MIPS CQM should be submitted as a 0 for 0. We're not going to go over the submission specifications in this webinar, but it may come up in the FAQ or in the Q&A. So I would just point out here what we have identified on slide 12. A 0 for 0 is the numerator and denominator for that registry submission. Third-party intermediaries must submit that accurately for the MIPS eligible clinician and group's population for the measure, even if no performance data was collected. All right, next slide. Now we're going to go through a kind of use case that examines the impact on performance category scoring with a use case that shows the application of EMMA. Next slide, please. Here's the impact at the quality performance category level with a normal understanding that the denominator should be 60 and the maximum number of measure achievement points for each of the 6 required measures is 10 points. So we have 10 points times number of 6 measures equals 60 points. In review of what we had just shared, if you submit less than 6 measures or don't submit an outcome high priority measure, the number of required measures may be reduced if EMMA finds that there are no more quality measures that you could have submitted. If we say you could have submitted more quality measures, the category denominator will not be reduced, and the missing measures or lowest scored measure for not submitting an outcome high priority measure will receive a score of 0 measure achievement points. So said differently, the denominator for the category of the quality category would not change depending on how the EMMA assessment is made. Slide 15, please. If you submit CQMs through a third-party intermediary, EMMA looks to see if any of the measures submitted apply to the clinical relationships mapped in EMMA quality measure relationships. Here are 4 examples that show the impact of EMMA assessments associated with submissions and the calculation examples to go with each use case. So what we have here is the use case walkthrough on 4 scenarios for EMMA. All right. Unless otherwise noted, all 4 measures have data completeness greater than 0. The calculation examples assume you earn 28 category points for the 4 measures you submitted, including your measure achievement points and bonus points. The calculation examples use MIPS scoring criteria standard performance category weights and assume there's no improvement scoring to factor into the quality performance category score. So let me just say that cleanly. We are using a kind of stripped down scoring logic for the 4 measures that says you have 28 category points. Let's look at what the denominator changes would be because of EMMA in the next couple slides. Slide 17, please. For our first check, we have EMMA has 0 clinically related unreported MIPS CQMs. So the maximum number of points you can earn in a category is lowered from 60 to 40. So remember, you scored 28 points. EMMA found 0 clinically related unreported MIPS CQMs, which lowers your denominator from 60 to 40. And our category weight in 2019 for quality is 45%, which generates a 31.5 points towards your MIPS final score. So once again, on slide 17, EMMA reduces your denominator by 20 points from 60 to 40. That results in a higher score than you will see in some of the other scenarios because EMMA found 0 clinically related unreported MIPS CQMs. Next slide. In this one, EMMA finds 0 clinically related unreported MIPS CQMs, and one of the 4 submitted measures has a 0% reporting rate. Therefore, the maximum number of points you can earn in the quality category is lowered from 60 points to 30 points. So here we have, again, your 28 achievement points, but our denominator is reduced even further to 30 maximum achievement points. Using our math for the category weight, we then result in 42 total points for your final score from the quality category. And that is because Emma found 0 clinically related unreported MIPS CQMs. And one of the 4 submitted CQMs had a 0% reporting rate. Next slide. In our third one, we have Emma determining 1 or more clinically related unreported MIPS CQMs. So the quality category denominator remains at 60 measure points. So with our standard numerator of 28 measure achievement points and our total maximum achievement point denominator remaining at 60, we have a big drop in our score from the quality category because Emma found reported CQMs that could have been reported. So essentially, there were clusters that are in Emma that did apply, and therefore the score is a little bit lower because the denominator remains the same. Slide 20, please. Great. In our last one, Emma finds 1 clinically related outcome or high priority measure. So the denominator remains 60 points, but only the top 5 scoring members contribute to your quality performance category score. In this instance, you receive 0 out of 10 for the available but unreported outcome or high priority measure. So again, we have a challenge where the numerator contributions and the measures reported missed an outcome measure that was associated with either the Emma logic or the set logic, and we have a missing submission. So then the bottom line is you're only getting 5 out of 6 measures scored, and you still have your denominator set at 60 points. Okay, next slide. Now I want to take a brief pause to make sure Stephen is on with us, and we're going to walk through what does this look like in JavaScript object notes or JSON for our systems, and a little bit in the back-end operations. Stephen, are you with us?
Hey, good afternoon, everybody. So we're going to start with what the UI representation of the Emma processing looks like, because the audience that we are demoing for is going to be associated with the registry submission details. That is the information we are going to show. I'm going to walk through the 4 examples that Tim just talked through and show kind of what the visual representation of that will be. The UI for the registry dashboard is still something that's a little bit under construction, so we're going to do a little bit of jumping around between the application to show how the UI is actually reflecting the behavior. And then once we get done with that, we'll do a brief walkthrough of kind of what it looks like from back-end processing, actually utilizing the API and what type of results we'll get out of the scoring engine. So as you can see what I'm showing right now, this is what the registry dashboard will look like once the submission period opens up. So we're going to walk through those 4 examples. I'm going to upload my file. I'm going to browse. I'm going to find the file that I'm looking to upload, select it, click upload. You can see that it's successfully been uploaded. You can see that my score has been updated. You can see I've submitted these 4 measures, and this is based off of the information that we have here. So what I'm going to do now is actually log out and sign into a user that is associated with the group.
Hi, Stephen. Looks like you just lost audio for a second. Could you just double check your connection, please?
My denominator has been reduced, which is being shown on the display. So at this point, you can see that each one of these is reflecting the information that I submitted. So I'm going to go back to the registry dashboard, which, as I mentioned, I apologize. We're going to hop around a little bit just to walk through the scenarios. So the second scenario that we are going to look at is going to take the submission object where I'm trying to report a cluster, but I do not have one of the applicable measures. So if I go back into my reporting dashboard, I'm going to delete my first submission that I made, and then I'm going to upload a new file. Once I upload my new information, you can see that my upload was successful. Again, you can see my score is being populated based off of the information that I have here. Navigate back over to the actual user and take a look at what they are seeing. So we've tried to make the experience as kind of intuitive as possible to demonstrate when users will be getting a reduction within the application. So that way there won't be confusion during the submission period. You will be able to see, real time that the data has been submitted. I am seeing again that my submission has met the requirements. I'm being scored off of the 3 measures that I have. And you can see that that last measure that's applicable is receiving a score of 0 because I submitted it as a 0 over 0. And then I'm only being scored on a denominator of 30. So the next one that we'll be looking at would be the third example, where we have submitted part of a specialty set or clinical cluster, and I'm reporting additional details that are outside of that. So the system's going to look at that and basically apply a score based on the information that's actually been submitted. Let's see, hold on 1 sec. For some reason, I did not want to copy. Why is it stopped? Log back in. I have too many users. Sometimes it's difficult to tell what is what. I know one of the requests that we've received a couple times is the update of documentation for those of which that are using the API. That is something that we are currently looking into to figure out the best way of introducing the data. We know that a lot of the information we've tried to provide has actually ended up being a bit confusing. So the metadata we ended up adding is probably going to end up being removed. So I'll kind of walk you through what that will actually look like as we're going through the JSON examples. So the third example that we have is where I'm uploading a file that has more measures than what's expected. You can see again that I'm receiving this real-time feedback. So I'm going to navigate back over to the test user. And then once I look at my overview, see that we have our submission score here. And I'm also being alerted that I have less than 6 measures, and the measures that I have submitted are not qualifying for the eligibility measure application. So the final will receive a score of 0 as it was not reported. And you can see that as going through, there are 5 measures here, and the score is based off of the information that I have submitted. The last example would be if you submit a submission that does not have a high priority measure, in which case you will only be scored on the top 5 scoring measures. The 6th measure will not receive a score. And we'll walk through that one to show what it looks like on the UI. So I'm going to delete out the submission that I have. We'll upload this final file. Let's see, it was successful. You can see my score populated. Navigate back over to the user. This is one other item that we are currently working through. So the information, there will be a modal that will be represented on the page once the submission period is actually open, letting the user know that because they did not submit a high priority measure, they are only going to be scored on the top 5. However, you can see that as we are looking at the information, we have one of these measures that's associated that's receiving a measure score of 0 because of the fact that it did not meet the requirements. The measures submitted did not have a high priority measure. And because of that, you can see that we are scoring and not getting this 5th example. So now I'm going to transition over to what it looks like from the actual API representation. So you can see my submission examples are going to be on the left, and then my scoring examples are going to be on the right of what we expect to receive back from the API. So let me grab this first submission that we walked through. And this one is going to be the submission that has all of the information that is meeting EMMA. It will be scored on the measures that are available. You can see that we are receiving all of our scores. And then as well, if we scroll down to the bottom of the submission, you can see that we have a denominator eligible of 40 because of the fact that we are meeting the criteria as submitted, and the score has been reduced based on the information. The second one is going to be an example where we are submitting a score, one of our measures that is just not available to the clinician because there are no eligible patients. You can see I'm submitting this one as measure 70. All the details associated would be submitted as a 0. As I send through the information, you can see that once again, we're receiving our response from the API that's giving information about all of the details. And then as we get down to 70, you can see it's been skipped because of the fact that it does not have information that's associated, and the score will be based on only the 3 measures that would be applicable, which we can see here as the denominator information. The next example that we are going to look at would be an instance where we are submitting information that has a measure outside of the submission or the set that we're looking to actually submit. So you can see that this has the same 4 measures I was previously reporting, but now I'm adding in measure 001, which is not a part of that measurement set. And we'll be able to see at the bottom that the denominator has not been reduced, and we are being picked on the measures that have been submitted, and the last measure would be receiving a score of 0 because we only have 5 measures that have been submitted. The last example will be an instance where a measurement set has been reported that does not have a high priority measure, but 6 measures have been reported. So in this instance, you can see at the top, the detail is based off of the weight of 60. And as we scroll down to the last measure that would be associated, you can see that 048 is receiving a detailed message of skipped because of the fact that max 5 has been reached. And then as we look down here, you can see that the max measurements allowed were 5, even though we have 6 measures submitted. So the score is going to be based off of the information associated with each one of the submissions, and then the details within the actual metadata coming back from the scoring engine will give you information about why and how the items have been scored. So from here, I'm going to pass it back to Lauren to give it back to Tim to finish out the remaining slides.
Great, thank you, Stephen. All right, we will move on. So Tim, it's back to you.
Great, thanks, Lauren. If we could go ahead and advance to the next couple slides, to slide 23, thank you. So we are going to review some of the additional process questions. So again, what Stephen showed you is the how. The question we get often is when. So as provided earlier, just a quick synopsis for Part B, EMMA is applied after the close of the submission period to ensure all claims have been processed. So when there's a claims runout period, we account for at the close of the submission period, which allows for a 90-day processing that then EMMA runs. And then if you have the MIPS CQMs, alternatively, EMMA is applied at the point of submission, which is exactly what Stephen demoed for you today, both within the QPP interface, and then also you were able to see within the JSON processing on the back end. So that processing, again, on the back end occurs at the end of the submission period for claims. For the registries that submit, it occurs at the point of submission, and there is a process that he just showed you as a way to do a quick verification of that. within the system. So next slide, please. Thanks, Lauren. What happens if my group doesn't meet the case minimums? So this is a slightly broader question than just EMMA, but it has implications. For submitted quality measures that meet data completeness but don't meet the case minimums, you or your group would earn 3 points for the quality measure, which EMMA will not change. EMMA is used if you submit less than 6 measures to find out if you should have submitted additional measures. Clinically related measures that are submitted or calculated with a 0% reporting rate will be excluded from scoring if they don't meet case minimums. So I'll say that last sentence again because it's one that I think we have often heard needed emphasis. So clinically related measures that are submitted or calculated with a 0% reporting rate, I'll say it one more time, a 0% reporting rate will be excluded from scoring if they don't meet case minimums. Okay, slide 25. What happens if my group or I don't meet the completeness requirements for one or more of the measures submitted? Your submission can still be eligible for EMMA even if one or more of your submitted measures don't meet the 60% data completeness requirement. However, the measures will only earn 1 achievement point towards your category score, or 3 points if you're in a small practice. Next slide. So this is kind of moving towards the logic that EMMA employs, and this is the specialty measure set and clinically related measures. Next slide. The specialty measure sets and related measures are either a subset of a specialty measure set or measures not included in a specialty measure set. If you submit the full specialty set for the data submission method you choose, EMMA won't apply. If you submit all of the quality measures from a specialty measure set with fewer than 6 measures, the quality performance category score denominator will be lowered to the number of quality measures in the specialty set, regardless of your submission method. So this is what I had mentioned in the earlier portion of the webinar, just reinforcing that. Next slide, please. You should submit all quality measures that apply to your scope of practice and not limit your submissions to clinically related measures. That's keeping in spirit of the program, as Dr. Green would say, and specialty measure sets were created to help you identify quality measures that apply to your specialty. We have many of those listed on the library page, and they do grow over time as we build them and finalize them through rulemaking. The eligible measure applicability process was established to support clinicians and groups who may not have 6 quality measures available for and applicable to their practice. Slide 29. You can find the measure sets in the Explore Measures tool in the 2019 performance year on the program website. The hyperlinks available here and also available on the qpp.gov website will take you to them. You will then filter for your specialty to find the measure sets. You can also find the EMMA clinically related measures for the 2019 Part B claims and 2019 for CQMs filed under the EMMA zip file, and you'll also find that in the resource library on the webpage for qpp.gov. Next slide. Measure sets are updated yearly through the rulemaking process, and we receive stakeholder input through public comments made in the Federal Register. And EMMA's clinically related measures are updated yearly through a sub-regulatory process, and we receive stakeholder input through collaborative review and feedback. So one is formal and through our notice and final rule, and EMMA is the second process, and that is sub-regulatorily conducted, and it involves looking at what makes the denominator appropriate EMMA checks and what does not. It can be very detailed and requires a lot of review. Next slide. Help and support available from the program to include questions about EMMA or getting resources is available through our SIRS and our technical support as provided here on slide 32. And we are always looking for participants to collaborate with us in giving feedback on your experience and questions. The research team invites you to participate in the human-centered design. Usually the research involves 20 to 30 minutes of interviews and feedback. It can last up to an hour by phone or webinar. And you feel free to reach out with the email address provided here on slide 33. Next slide. Now we're going to open up, I think, for our Q&A session, Lauren.
Yes, thank you, Tim, and thank you, Stephen, for your demo. So everybody, we will now begin the Q&A portion of this webinar. If you would like to ask a question or have Tim or Stephen explain anything, please submit your question via the questions tab to the right of your screen. So we've got a few to begin with. So Tim's first question asks, how does EMMA work if a person submits via claims and a QCDR, for example, asking since EMMA does not apply to QCDR reporting?
Right, so EMMA would not be applied to that combination of collection types because the policies that are built to provide for EMMA do not support the QCDR submission process. So in that instance, if they submitted 2 claims measures and 2 QCDR measures or some combination thereof, there would be no EMMA applied to the quality category scoring for that submission. So again, with my example, kind of back to the webinar, if they gave us 2 claims and 2 quality QCDR measures, we would end up with 4 out of 6. So their denominator would be 60, and they would get scored off of their 4 measures, assuming those are the only 4 measures that they provide, and they meet the data requirements and data completeness requirements. So again, 40 out of 60 would be their best score, assuming that one of those 4 included an outcome measure. Thanks for the question.
Great, thank you for that. All right, your next question asks, when does CMS complete the EMMA process, and is anything commuted to the eligible clinician or group if the EMMA process turned up measures that should have been reported?
Yes, so in this slide deck, about a third of the way through, we talked that through, and Stephen also showed on the slides within the demo. I believe since this will be on posted to the YouTube channel, if you go backwards in time to somewhere around the last 10 minutes from now, you should see the review of what the feedback looks like within the NPI level experience as they see their feedback. So for claims, the claims EMMA process runs after submissions is closed. So in 2019, that will be after March 31st, 2020. EMMA for claims will be employed. And for CQMs that come through a registry submission, the logic will be applied at the time of submission. So the submitting organization or entity or vendor, whatever it may be, could then look at what the NPI view would show, and that should, as Stephen demoed, should clearly state EMMA applied or there was a missing measure. And again, that's following the logic of EMMA. It is not showing measures that did not apply. It only shows what would have applied. And thanks for the question.
Also, just to kind of tag on to that as well, there isn't anything specific that's going to say, hey, we noticed you submitted part of cluster X and you're missing, these 2 measures. It's really only going to say, as Tim said in the beginning, this is really kind of a true-false function of if you met it, then it will give you a message letting you know that, hey, you met the requirements for submission. And then in the case that you didn't, it will either let you know that you haven't met it or you just won't see a reduction in your denominator.
Thanks, Stephen.
Great, thank you both. All right, next question is saying, will all QCDR or JSON files capture the 0 data measures?
So I'm not sure I understand the question. If there's a 0 for 0 QCDR measure submission, that would not apply to EMMA because it's a QCDR measure collection type. The QCDRs do not have EMMA available to them. That was not provided for in policy, and so programmatically and operationally, QCDRs will have no EMMA reductions if they have a QCDR submission as part of their measures submitted to the quality category for any clinician or group. We may need a restatement on that one, Laura. I don't know if that's possible. I'm not sure if the commenter, I can't really see it. I'm sorry, I'm scrolling, but you may want to rephrase it.
no worries. Again, if you ask that question, please rephrase and we will try to address it. All right, so in the meantime, we have another question giving an example. So let's say that an EMMA cluster includes 3 measures. What if a clinician reports those 3 measures plus a 4th measure that is not in a clinical cluster? How would CMS treat that scenario since one of the measures is not associated with other measures? And could the clinician still qualify for reweighting?
So let's just clarify really quick. So yeah, Stephen, did you want to talk this one? I just want to clarify about the reweighting. Go ahead.
So essentially, this would be our example that we showed as number 3. The expectation is one reporting, if you are reporting a specialty set or clinical cluster, that you are reporting the measures that exist within there. If you submit measures that do not match the clinical clusters or specialty sets, the system will not award any type of reduction in that case.
Yeah, this is Tim again. So let me just reiterate that. So if we get an EMMA plus 1 submission, so I have my CQMs and I want to go 3 plus 1, so the cluster was 3 or the cluster was 4, and I want to submit a 5th one, that basically violates the EMMA logic, because there is no provision for EMMA plus. It is not. It's simply doing the same process of sending in a QCDR measure with it. You're going to look for 6 measures because you just said eligible measure applicability is an if this then that check, and you just said I don't need that because I want to do if this then that plus what I want or what I believe, and that is available to you. But the default logic is as we laid out at the beginning of this webinar and laid out in our policies and our performance guides and our category guides and the specialty sets, which is 6 measures are expected. And that's the default. Thanks for the question.
All right, thank you. All right, your next question asks, does this mean that for EMMA, we will be calculated in real time for performance year 2019 reporting? So in theory, practices who are participating in a registry will be able to hit submit, receive the API token with predicted MIPS score, and then immediately log into their HARP account to see how the predicted score was calculated, including the application of EMMA.
As long as you are meeting the criteria for the measures that are associated, I know there was some confusion last year. So very important to notate that for this year, we are not allowing the combination of measurement sets for EMMA reduction. So in the instance, you're reporting 2 measures via claims and 2 measures via registry and thinking that that will align with one of the specialty sets, that will not result in a reduction. As well as if you are not submitting a registry specialty set, the claims specialty sets cannot be submitted via the registry mechanism. I know there was some confusion around that as well. So the the idea is that if there is a clinical cluster or specialty set that one contains less than 6 measures, is the first check, because if you're submitting only part of a clinical cluster or specialty set that has 6 or more, that will not be eligible for reduction. But if you are meeting all of the criteria as I demoed today, it will be real time. The API will provide back real-time response showing you, if you're using the API, that there is a reduction being applied based off of the denominator information as part of the scoring response, as well as you can log in. Everything that I showed today was what the functionality exists within within the implementation environment, which will be the same type of functionality that will exist within production. So if the registry is submitting data for a user, they could submit it, and then either if they have the ability to log in as the user or contact the user and ask them to look, if there is no reduction being applied, you most likely are not meeting the criteria that would be required.
Okay, great. Thank you very much for that. Now we do have a clarifying question on the one asked earlier. So basically asks, will all QRDA3 and GSON files capture 0 data measures? Does that help?
So EHR measures are not eligible for the EMMA reduction. If you are submitting either a registry, trying to submit a registry type measure as listed as end-to-end, this will be rejected by the API validation this year. If you are reporting the end-to-end version of a measure that has a corresponding eCQM, the expectation is that it would be submitted as an EHR measure.
All right, thank you for that. All right, next question asks, what happens if a user submits 2 complete EMA sets?
So that would, again, I mean, if you're reporting 2 EMA sets, then most likely you're going to have 6 measures. There are only a couple that are registry type that fall into that category of less than 3. But again, this would not fall into the criteria. You can submit 1 specialty set or clinical cluster. You cannot submit 2 or mix and match between 2 different ones. It must be all or nothing related to what is submitted.
All right, thank you for that. Okay, so next question asks, if a QCDR supports QPP measures and the submission includes only QPP measures, so there are no QCDR custom measures, would the EMA process still apply?
Yeah, so this is Tim. So I just want to make sure we're getting the question clearly. So a QCDR is submitting only CQMs. Is that what is being asked?
Here, I can go ahead and re-ask that.
Yeah, that's
sorry.
That's
Thanks,
what it
Lauren.
sounds like, Tim. Basically, they're asking if they are a QCDR and they're only supporting the MIPS CQM measures, and there are no QCDR measures if they're submitting for clinical clusters or specialty sets.
Yeah, to my knowledge, then that would be allowed if that is what the QCDR has been approved to submit upon within their self-nomination process, then that is allowed. But we would have to double check with the QCDR team to see if there are any provisions with that. Stephen, did you have any other input?
Yeah, I did. This is something that's come up a couple times. I believe that because the whole idea behind being a QCDR is that you are supporting measures that exist outside of the MIPS CQMs that are available for reporting. The expectation would be that you are submitting the measures that you have submitted through the self-nomination process that have been approved by CMS for submission.
That's my knowledge as well, but I don't know that there is a disallowance or disapproval set from the QCDR team. But we would follow up on that, and we can follow through with that team and make sure that's provided for in a one of their monthly calls. Thank you.
Great, thank you both. All right, so clarifying question. They want to make sure that EMA will only affect those with less than 6 measures. Is that correct?
Yep. So as Tim kind of outlined in the very beginning, the first check that's done is if the submission has 5 or less measures. So if the submission has 6 or more measures, there will be no type of reduction that would be applied.
Wonderful, thank you. All right, next is, can they pick and choose measures from the clusters for a specialty?
Yeah, so this is a question we've got that comes through. So with the picking of measures based off clusters, I'll be honest, we usually get this about like 3 days before submissions close from various vendors that are trying to figure out how to help clinicians. And it's not disallowed or disapproved, but it does send up flags for review from our various teams within CMS, to include the audit team, to review. And to be clear, based off of some of the target review scenarios that we have rejected, it's usually because people try and pick clusters without understanding the full import of what they're doing. And so they think that if they do a partial cluster, then they can come back and get full credit because they intended to do the full cluster and they have extenuating circumstances and so on and so on. So I would strongly discourage from trying to use the clusters as a way to work around the program. There are multiple options available, and the combination of collection types available in year 3 allows for a combination that essentially removes a lot of that necessity. That's not saying I don't expect people to be scrambling at the last minute, but I expect that if you are scrambling at the last minute and you aren't careful in what you're looking at, you probably won't be happy with the outcome.
Noted, thank you. All right, next question asks, if EMMA was applied and found that other measures could have been reported, how can one find out what those measures are?
So all of the specialty sets and clinical clusters are public-facing documentation. So you would be able to go out to the QPP measures library and download either the specialty sets, which are a part of the measures information guide, or you could download the clinical clusters that would be available for reporting via registry. That would be the recommendation, at least from a submission perspective, of trying to verify what type of information is out there. The resource library on qpp.cms.gov does have a lot of information that can be helpful in trying to find that.
Great, thank you. All right, next question asks, we've been saying EMMA doesn't apply, in some scenarios. So when you say that, does that mean that the denominator will always be 60 if EMMA does not apply to one situation?
Yeah, this is Tim. So the denominator is set by the policy weights, and the expectation is 6, except in the instances as described early in the webinar with the specialty sets. So some specialty sets have more or less than 6 measures, and so therefore the denominator would still be at what it is set, but the number of measures, as we demoed, could be less.
All right, thank you for that clarification. All right, next question asks, how are practices or providers who are eligible for EMMA identified before MIPS submission?
So identifying this should be based off of your practice type. So if you have the ability to submit more measures that are available, the expectation wouldn't be to go through and find a submission type that would contain less than 6 and report those measures. Most of the time it's based off of the clinical association based off of your practice. So there is the single source guide that also has information where you can check out your denominator codes to see what type of measures you might be able to report. In general, though, the program requirements are that 6 measures are required. This is not a way to kind of sidestep that. The program does expect for 6 measures to be reported the majority of the time.
And yeah, this is Tim. The only thing I would add to that, again, and I mentioned it a few minutes ago, which is employing the cluster logic to avoid reporting on measures could result in tripping audit methods. For practical examples, if you're a large single specialty practice and you look to do a set that's or try and employ a cluster that's looking for something that is a little bit not associated with what is normally submitted for your collection type, and you are also not submitting the set, and you are also not submitting 6, and so on and so on and so on. Just like the thresholds that apply the software for EMMA to apply, we also have methods that look for outliers based off of performance that follow the same kind of logic for folks. And it's always interesting to watch entities explain why they pick measures they really didn't do any work on, to put it bluntly.
All right, thank you. So we're getting a few questions about this. So wondering if you could please clarify just one more time if EMMA would apply when a clinician submits a combination of claims and CQMs.
No. One of the program goals is to open up the ability to submit via multiple mechanisms, which in the case that if you are submitting via multiple mechanisms, being able to find 6 measures should be possible. So if you are reporting 2 measures via claims and 2 measures via registry, and you think that it would apply for the EMA processing because the measures align with one of the clinical clusters, it will not be reduced. And there will be no type of denominator reduction associated with the submission.
Right, helpful. Thank you for that. Okay, so the next question is talking about slide 24. I will try to go back while you're answering the question, but in the meantime, the question asks, if an eligible clinician has only 6 eligible measures, but the 6th measure has less than 20 eligible encounters, should the eligible clinician not report that 6th measure so that EMA is triggered and their denominator is rebased to 50, or must they submit that 6th measure and be forced to accept only 3 points?
So in the case that they're describing, that means that they have 6 eligible measures to submit. The expectation is you are submitting all measures that are applicable to you by practice type. If you just submit 5 measures, that will not result in a reduction. The only time that a reduction would be applied would be in the instance that you are submitting a clinical cluster or specialty set that has 5 or less measures. So if they have 6 measures, they should definitely report the 6th measure because receiving a score of 3 is better than receiving a score of 0.
Okay, great. Thank you for that clarification. Okay, your next question asks, if an EP is doing claim submissions for 4 quality measures and then later submits a subset of an EMA cluster via registry, will the results of the EMA process still apply?
I'm sorry, Lauren, can you read that one again, please? I'm sorry.
Of course, no worries. If an EP is doing claim submissions for 4 quality measures and then later they submit a subset of an EMA cluster via registry, will the results of the EMA process still apply?
So this goes back to the same question we just answered. Reporting via multiple mechanisms will result in no reduction for scoring. The only time that we will assess the correlation with a specialty set or clinical cluster is in the instance of only one submission type and a one-to-one correlation with the corresponding specialty set or clinical cluster that is in relation to that submission type.
All right, thank you for that. Just a general notice, we are getting a lot of questions, which is wonderful. However, please note that in today's webinar, we will only be able to answer questions that are relevant to the EMA process and that talk about the EMA process in general. If you have questions particular to your situation or that are slightly more nuanced, please feel free to refer your question to the service center with a bit more information where they will be able to help you. Okay, so moving on, your next question refers to slide 12. So related to the 0-0 submission for a measure, does that submission Does that submission only apply to measures that are in a specialty set being reported, but that are not clinically applicable to the eligible clinician or group? Or is there another example of when a 0-0 submission would be required?
Yeah, so the only time that a measure should be submitted as 0/0 would be in the instance that you are reporting a clinical cluster or specialty set and have 0 eligible population for that measure. Outside of that, there is no reason to submit a measure as 0/0 as it will not award any type of score or be validated for scoring criteria.
All right, thank you. All right, next question asks, for small practice and non-patient facing hospital-based only practices, as in radiology, most of the claims measures are now being topped out. So it looks like the future will offer less than 6 measures as a result. Can you clarify? And if so, what's next?
so that is a good point. Unfortunately, we are not equipped to address the scoring differentials and the determination of topped-out status with the folks on the call at this time. We'll be happy to take that to one of our future meetings, so if we can capture that for follow-up with another team. Thanks, Lauren.
All right, thank you for that. Okay, so this question is slightly more nuanced. So if a clinician believes that only 2 measures apply to them, and after they submit billing data to a qualified registry, they are also determined, and they also determined based off claims submitted to the organization only had 2 eligible measures, and upon final feedback, CMS says that they could have submitted more. Basically, does that mean that you don't have to tell the organization which measures they could have submitted on? How would the organization find additional measures that they could have submitted on for either that year or for future years?
So as I mentioned, the single source is a great place to start, as well as the QPP resource library. You can do searches based off of keywords where you could try and type in, association with what your practice type is, and might be able to show some measures that are available. In the instance where only 2 measures are submitted that do not match any type of specialty set or clinical cluster, that will not result in any type of denominator reduction.
Great, thank you. All right, next question asks, are you allowed to submit a clinical cluster without submitting a specialty submit? So for example, submitting the anesthesiology care cluster without submitting the entire anesthesiology specialty set.
So this again is going back to the 1-for-1 correlation. Whatever you are trying to submit, you need to make sure that you are matching the information that's associated with your submission type. For example, if you are reporting via registry, which most of you I'm guessing would be, you can't try and report a claims clinical cluster or a specialty set. Those do not align, they're not correlated. So at that point, if you submit those and are expecting to receive a reduction, that would not be applied because it does not match the expectations.
All right, thank you for that. Okay, and next question, and just a general notice to the group, we are running low on questions, so please feel free to submit your questions via the questions tab if you do have any underlying concerns or any follow-up questions. We have this time, and otherwise we can wait. All right, but your next question asks, in regards to the previous question about whether or not to report a 6th measure that didn't meet the case threshold. If the clinician only reported on 5 measures, isn't it possible that the 6th measure would have been determined to be eligible, but because it doesn't meet the minimum threshold, it would be removed from the denominator?
No.
No.
The meeting the threshold has nothing to do with anything other than clinical clusters or specialty sets that have less than 6 measures associated. So if you don't want to report because you think that you have less than the case threshold, that's just going to result in a score of 0. There won't be any reduction that's associated regardless of whether or not you are reporting the 6th measure or if you are reporting the measure that's below the threshold.
Okay, thank you for that clarification. All right, so next question is on eligibility for EMA. So if a physician qualified for EMA in 2018, will they still qualify in 2019, or have there been any changes to eligibility requirements?
Go ahead, Steve.
The measures are updated year by year. So that would be a responsibility of going out and checking the updates to the specialty sets or clinical clusters. They do get updated. So there is the possibility that if it was applicable last year, it might not be because we've introduced new measures. So I would definitely recommend going out and checking out the resource library and seeing if the specialty set or clinical cluster that you reported last year has changed.
Sorry about that, I was on mute. We just got a clarifying question to the earlier question to reporting on a sixth measure that didn't meet case threshold. So the clarifying question asks, what happens if the sixth measure was part of a cluster that was otherwise satisfied? Does that change the situation?
No, because again, the reduction process only looks at clusters or specialty sets that have 5 or less measures. So in the instance that there are 6 or more, there will not be a reduction that would be implemented, regardless of what was reported as the sixth measure and whether or not it met the threshold.
Okay, thank you for that. All right, next question. It looks like we have time to take a few more if you do have any, and if not, we are able to end the webinar early. So again, if you have any final questions, please feel free to submit now. Next question for you asks, is it new for 2019 that a measure with less than 20 patients could be marked by CMS as should have been submitted if found in the EMA process?
The expectation is that you are reporting on all measures that are applicable. So in the case that you are reporting information and you have less than 20, you should still report that information. It's not something where you can just not report it, because you should report the measures that are applicable.
All right, thank you. All right, next question asks, please explain why the EMA criteria does not apply to measures that are submitted electronically via our data submission vendor. So is that a limitation referenced in the rule? And if so, could you let us know the reference, post it, and is there any recourse for that decision?
Yeah, so this is Tim. We can provide that, and we'll provide that separately, but I believe that's available in several of our other materials, which we will cross-reference for the respondent, but we'll do that separate from this webinar.
Okay, great, thank you. All right, it looks like we are running out of questions. Tim and Stephen, if you'd just like to quickly follow up on where participants are able to find any resources for the EMA process or the available list, that'd be great. And we will let you know following if there are any final questions that come in.
Yep, so essentially, as I've mentioned, if you go to qpp.cms.gov, there is the resource library that is associated with that underneath of the About tab on the top right-hand corner. There are a bunch of links underneath of the support resources that you can click through that has information about different submissions and other information associated with the program. There is a lot of good information on qpp.cms.gov in general to try and help with the reporting process, as well as provide as much detail as possible for the upcoming submission period.
All right, thank you for that. All right, just had one final question come in. It asks, if a specialty set contains 6 measures and the practice only has eligible cases for 2 of the 6, would they report the 4 remaining measures as 0/0, and would EMA apply in that case?
If there are 6 or more measures in the specialty set or clinical cluster, then the whole EMA process is never even evaluated. It is only for specialty sets or clinical clusters that have 5 or less measures that are applicable.
Great, thank you. All right, just a general note as we wait just to see if there are any final questions. Again, in this webinar, if we weren't able to get to your question, please note it may be something for the service center if it requires a little bit more information. And again, we are only able to comment on anything related to the MIPS process for 2019. So again, take a look at those resources. And otherwise, Tim, I will pass it back to you to close out the webinar.
I just want to say thanks to everyone and for all the questions. We did get, I think, some more questions in the queue that will be more clinically related and or policy related, and we will do the best we can to acknowledge and respond to those. I would look for that feedback coming through our monthly webinars for registries and QCDRs, as well as responses. If you have any other follow-up questions that you felt weren't answered, feel free to reach out to the Service Center for an inquiry. But please do check out all the materials and resources available, and we appreciate your time. Thanks so much.
Thanks, everybody.